Pulmonary embolism: what happens when a blood clot reaches the lungs? Imagine standing up from your desk, walking across the room, and suddenly noticing that your breathing feels wrong. Maybe you cannot take a satisfying breath. Maybe there is a sharp pain in your chest when you inhale. Maybe your heart is racing for no obvious reason. Those symptoms can come from many different conditions, from anxiety to pneumonia to heart problems. But one important possibility is a pulmonary embolism, often shortened to P, a blockage in an artery of the lungs, usually caused by a blood clot that traveled there from somewhere else in the body. A pulmonary embolism is not something a person can diagnose from symptoms alone. Some people have very obvious warning signs. Others have mild or unusual symptoms. And some of the same symptoms can happen in much less dangerous conditions. The key is understanding what a P is, why it happens, how doctors look for it, and when symptoms need urgent medical attention. This information is for general education. It cannot tell you whether you personally have a blood clot, and it should not replace an evaluation by a qualified healthcare professional. To understand a pulmonary embolism, start with the body's circulation. Blood leaves the right side of the heart and travels into the lungs through the pulmonary arteries. In the lungs, blood picks up oxygen and then returns to the left side of the heart, which pumps it through the rest of the body. Now imagine that a blood clot forms in a deep vein, most often in a leg or the pelvis. This is called a deep vein thrombosis or DVT. A piece of that clot can break loose, travel through the veins, pass through the right side of the heart, and enter the arteries of the lungs. When it becomes lodged there, it can block blood flow. That blockage is a pulmonary embolism. The effect depends partly on how much of the lung circulation is blocked and how well the heart and lungs were functioning before the event. A small clot may cause relatively mild symptoms. A larger clot, or several clots, can suddenly increase the pressure the right side of the heart has to pump against. In severe cases, the heart cannot keep blood moving effectively enough, blood pressure can fall, and organs may not receive the blood and oxygen they need. That is why pulmonary embolism exists on a wide spectrum. It is not always the dramatic collapse shown in television medical scenes. It can begin with shortness of breath that feels strangely out of proportion to what you are doing. It can cause chest pain that becomes sharper with a deep breath. It can cause rapid breathing, a fast heartbeat, lightheadedness, or fainting. Some people cough, and a smaller number may cough up blood. One of the most important things to know is that these symptoms are not specific to P. Shortness of breath can happen with asthma, pneumonia, heart failure, anemia, panic attacks, and many other conditions. Chest pain can come from the muscles and ribs, the stomach and esophagus, the heart, or the lungs. A fast heart rate can appear with fever, dehydration, pain, or stress. So the goal is not to hear a symptom list and diagnose yourself. The goal is to recognize when the combination of symptoms and circumstances deserves professional assessment. Pulmonary embolism often begins with a deep vein clot, but a DVT can be easy to miss. When symptoms do occur, one leg may become swollen, painful, tender, warmer than the other, or discolored. The discomfort may feel like cramping or soreness. But some deep vein clots cause few or no noticeable symptoms, which means a person can develop a P without first realizing there was a clot in the leg. Why do these clots form in the first place? Doctors often think about three broad forces that favor abnormal clotting. Blood may be moving too slowly. A vein may be injured. Or the blood may be more likely than usual to clot. These forces can overlap. Reduced movement is a common example. After major surgery, during a hospital stay, while recovering from a serious illness, or when a leg is immobilized in a cast, blood can move more slowly through the deep veins. Long periods of sitting during travel can also contribute, especially when other risk factors are present. Surgery and major injury can increase risk in more than one way. They may damage tissues and blood vessels, reduce mobility, and trigger the body's natural clotting response. This is one reason hospitals pay close attention to blood clot prevention in patients whose individual risk is high enough to justify it. Cancer can also raise the risk of venous blood clots. The cancer itself, some treatments, surgery, hospitalization, and reduced activity may all contribute. Pregnancy and the weeks after delivery are another period when the body is more prone to clotting. Estrogen-containing medications, including some forms of hormonal contraception and hormone therapy, can increase risk in some people as well. Age matters, but pulmonary embolism is not limited to older adults. A previous DEPT or P is an important risk factor. So are certain inherited or acquired clotting disorders. Obesity, smoking, and some chronic medical conditions may also add to risk depending on the person and the situation. The most useful way to think about risk is not as a single yes or no factor. Risk often rises when several factors occur together. A person recovering from surgery who is also less mobile and has a history of a previous clot may be in a very different risk category from a healthy person who simply sat through a long movie. There is another reason P can be difficult to recognize. Symptoms may change with activity. A person may feel almost normal while sitting, then become unexpectedly breathless after walking across a room or climbing a few stairs. Others notice only a vague pressure, unusual fatigue, or a sense that their heart is pounding. These symptoms are not enough to identify a P, but they are a reminder that serious conditions do not always begin with dramatic pain. It is also possible for oxygen readings to look reassuring in some people with pulmonary embolism. A normal reading on a home pulse oximeter cannot safely rule out a clot, just as an abnormal reading does not prove one is present. Consumer devices can also be affected by circulation, movement, nail products, skin temperature, and other factors. If symptoms are concerning, the decision to seek care should not depend on a single home measurement. Another common misconception is that only people who have been completely bedridden develop blood clots. Immobility is an important risk factor, but clotting risk is more complicated than that. Some people develop DET or P after relatively ordinary periods of reduced movement when other factors are present. Others develop a clot without a clear provoking event at all. That is why clinicians look at the whole medical picture instead of using one risk factor as a pass or fail test. And sometimes a clot occurs without an obvious temporary trigger. Doctors may call this unprovoked venous thromboembolism. That does not automatically mean something hidden and catastrophic is happening. It does mean the medical team may think more carefully about the person's history, age, medications, family history, and whether any additional evaluation is appropriate. Now consider what happens when someone arrives with symptoms that could be a pulmonary embolism. There is no single symptom, physical exam finding, or routine blood test that can confirm P by itself. Doctors combine information. They look at the nature and timing of symptoms, vital signs, medical history, recent surgery or travel, medications, pregnancy status, when relevant, previous clots, cancer history, and other possible explanations. They may use a structured clinical assessment to estimate how likely P is before ordering certain tests. This matters because testing everyone in exactly the same way would expose many people to unnecessary scans, while testing too little could miss a dangerous clot. In people whose clinical probability is low enough, a blood test called D-dimer may be useful. D-dimer is a substance associated with the breakdown of blood clots. A low result in the right clinical setting can help doctors rule out P without a lung scan. But an elevated D-dimer does not prove that a pulmonary embolism is present. D-dimer can rise for many reasons, including age, infection, inflammation, pregnancy, recent surgery, and other medical conditions. When imaging is needed, a test called pulmonary angiography, or KPA, is commonly used. It is a CT scan performed with contrast material so doctors can see the pulmonary arteries and look for a clot. Depending on the person's situation, another option may be a ventilation perfusion scan, often called a VE scan, which compares airflow and blood flow in the lungs. Ultrasound of the legs may also be helpful if a DET is suspected. Other tests such as an electrocardiogram, chest X-ray, blood tests, oxygen measurement, or an ultrasound of the heart may help assess the person's condition, look for strain on the heart, or identify another cause of the symptoms. This diagnostic process is important because pulmonary embolism can resemble many other problems. The safest approach is not to assume that every episode of chest pain is a clot, and not to assume that a clot is impossible because the pain seems mild. If a P is confirmed, treatment depends on how serious it is, the person's bleeding risk, other medical conditions, and what doctors believe caused the clot. For many patients, the main treatment is an anticoagulant, often called a blood thinner. That name is slightly misleading because these medicines do not literally make blood thin. They reduce the blood's ability to form new clots and help prevent an existing clot from growing while the body gradually breaks it down. There are several types of anticoagulant medicines. The choice can depend on kidney function, pregnancy, cancer, other medications, bleeding risk, cost, and many other factors. The duration of treatment also varies. Some people need treatment for a limited period after a temporary risk factor such as surgery. Others may need longer treatment when the chance of another clot remains high. This is why anticoagulants should not be started, stopped, or changed based on general information from a video. They can prevent serious clots, but they can also increase bleeding risk. Treatment decisions need to be individualized. People with a severe pulmonary embolism and dangerously low blood pressure may need more aggressive treatment in the hospital. In selected high-risk situations, doctors may consider medicines that actively dissolve clots, called thrombolytic drugs. These can be life-saving, but they also carry a significant risk of serious bleeding, so they are not routine treatment for every P. Some patients may be candidates for catheter-based procedures that remove or break up clot, or for surgery to remove a clot. These approaches are generally reserved for specific situations and are guided by specialists. The exact choice depends on how unstable the patient is, the location of the clot, available expertise, and whether the risks of intervention are justified. An inferior vena cava filter, sometimes called an IF filter, is a small device placed in a large vein to catch clots before they reach the lungs. It is not a standard substitute for anticoagulation. It may be considered in selected situations, such as when anticoagulation cannot be used or has failed under particular circumstances. Whether a filter is appropriate is a specialist decision. Once the immediate danger has passed, recovery becomes the next part of the story. After diagnosis, many people also wonder whether the clot simply disappears overnight once treatment starts. Usually, that is not how recovery works. Anticoagulants mainly prevent the clot from enlarging and reduce the chance of new clots, while the body's own systems gradually remodel and break down clot material. Symptoms can improve before imaging looks completely normal, and routine repeat scans are not automatically needed for every person. Follow-up decisions depend on symptoms and the clinical situation. People taking anticoagulants also need practical safety guidance. Depending on the medication, clinicians may review kidney function, other prescriptions, over-the-counter drugs, and the person's bleeding risk. It is especially important to tell healthcare professionals, dentists, and pharmacists about anticoagulant use before procedures or when new medicines are being considered. Even common non-prescription medicines can sometimes affect bleeding risk or interact with treatment, so checking first is safer than assuming a product is harmless. Some people feel much better within days or weeks. Others notice fatigue, reduced exercise tolerance, breathlessness, anxiety, or a sense that their body has not returned to normal as quickly as expected. Recovery can vary considerably, and persistent symptoms deserve follow-up rather than being automatically dismissed. A small proportion of people develop a long-term complication called chronic thromboembolic pulmonary hypertension, or CEPH. In this condition, persistent organized clots and changes in the lung blood vessels keep pressure abnormally high in the pulmonary circulation. ongoing breathlessness, fainting, unusual fatigue, or reduced exercise capacity months after a P may prompt doctors to investigate for this and other causes. Another concern is recurrence. Having had one DET or P can raise the chance of another, although the level of risk depends strongly on why the first event happened and on the person's ongoing health. This is where follow-up with a healthcare professional matters. Questions worth discussing may include: what probably triggered my clot? How long should I take anticoagulation? What bleeding symptoms should I watch for? Do any of my other medicines interact with treatment? Is my risk temporary or ongoing? When can I return to exercise or travel? Do I need compression stockings? Should family history or possible clotting disorders be evaluated? Not everyone needs the same tests, the same duration of treatment, or the same lifestyle advice. Good care is tailored to the individual rather than based on a universal checklist. Can pulmonary embolism be prevented? Sometimes, yes. Prevention is especially important during periods of higher risk. In hospitals, clinicians may use individualized measures such as early movement, mechanical compression devices, or preventive anticoagulant medication when the benefits outweigh the bleeding risk. After certain surgeries, patients may also receive a prevention plan for the recovery period. For long travel, the practical goal is to avoid being completely immobile for prolonged periods. When it is safe to do so, getting up periodically, moving the ankles and legs, and changing position can help keep blood moving. Staying reasonably hydrated is also sensible for general health, although drinking water by itself does not guarantee that a clot will be prevented. People at particularly high risk should ask their healthcare professional whether they need specific precautions for travel. It is not a good idea to take aspirin or prescription anticoagulants on your own just because you are boarding a long flight. Those drugs have risks and are not appropriate for everyone. Regular physical activity, avoiding smoking, and working toward a healthy weight may support overall cardiovascular health and may reduce some contributors to clot risk. But lifestyle habits are only one part of the picture. A very active person can still develop a clot after surgery, during pregnancy with cancer, or because of an underlying clotting tendency. That distinction matters because prevention should never turn into blame. Pulmonary embolism is a medical condition with many possible risk factors, and sometimes it happens even when a person has done everything that seems sensible. There is also an important conversation around hormonal medications. If someone has a personal or strong family history of blood clots, they should discuss that history with a clinician before starting estrogen-containing medication. That does not mean everyone should avoid these treatments. It means the balance of benefits and risks should be considered in context. The same principle applies after surgery or hospitalization. If you are being discharged after a period of reduced mobility, it can be useful to ask whether you have any specific blood clot prevention instructions, how active you should be, and which symptoms should prompt urgent care. Now, when should someone seek medical help? New, unexplained shortness of breath, chest pain that is worse with breathing, cutting up blood, fainting, or a sudden fast heartbeat can be symptoms of pulmonary embolism, but they can also signal other serious conditions. These symptoms deserve prompt medical assessment, especially if they are sudden, severe, or occur in someone with recent surgery, hospitalization, immobilization, pregnancy, cancer, a previous clot, or another important risk factor. Possible DET symptoms such as new one-sided leg swelling, pain, warmth, or discoloration also need timely medical evaluation. A leg clot can sometimes be treated before it travels to the lungs. There are situations where the advice is more urgent. If someone has severe or rapidly worsening difficulty breathing, collapses or faints, has severe chest pain, becomes confused, develops bluish or gray lips or skin, or appears critically unwell, seek emergency medical help immediately using the emergency number in your country. Do not try to drive yourself if you are severely unwell or at risk of fainting. If a person is already taking an anticoagulant and develops signs of serious bleeding, such as vomiting blood, passing a large amount of blood, having black tar like stools, Experiencing a severe unexplained headache after an injury, or developing other concerning bleeding symptoms, urgent medical evaluation may also be needed. A clinician can advise what level of care is appropriate. The central lesson is simple: pulmonary embolism is serious, but it is also treatable, and medicine has well-established ways to assess risk, confirm the diagnosis, and choose treatment. What makes P challenging is that it does not always announce itself clearly. Shortness of breath may seem like stress. Chest pain may feel like a pulled muscle. A swollen leg may seem like a minor injury. Most of the time, those symptoms will have other explanations. But when they are new, unexplained, or connected to meaningful risk factors, they should not be ignored. Understanding the condition is not about becoming afraid of every H or every fast heartbeat. It is about knowing the pattern well enough to respond appropriately. A pulmonary embolism begins with a problem in blood flow and clotting, often far from the lungs. The clot travels, blocks part of the pulmonary circulation, and can place sudden strain on the heart and lungs. Symptoms vary. Diagnosis requires clinical judgment and testing. Treatment is usually centered on anticoagulation, with more intensive therapies reserved for selected severe cases. Follow-up matters because recovery, recurrence risk, and treatment duration are different for every person. And if there is one practical point worth remembering, it is this: sudden unexplained breathing difficulty, chest pain with breathing, fainting, or coughing up blood should be taken seriously. If symptoms are severe or rapidly worsening, seek emergency medical help immediately. Knowledge should make health decisions calmer, not scarier. The purpose of learning about pulmonary embolism is not to diagnose yourself. It is to recognize when the body may be signaling a problem that deserves professional attention, and to understand what happens next when medical teams investigate it.